Good afternoon, and thank you for joining us for today's webinar, Addressing CBCT Radiation Exposure. Before we begin, I'd like to go over a few housekeeping items. Today's webinar will be recorded and available through our website. To minimize noise and distraction, all attendees' mics have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using our Q&A box. We will do our best to address all questions and comments at the end. I will now turn the presentation over to our moderator, Dr. Durairaj, West Physics Regional Vice President and Senior Medical Physicist. Thank you.
Thank you, Kristen. Okay, so hi everybody. Welcome you all to the RadSite webinar. So we have a very good panel of experts here that we're going to talk about a very specific topic today. Before I go further into the topic, let's go around the table and get us all introduced. I will just start with David, and please, David, go ahead and introduce yourself.
Thank you very much, Vino. I'm David Georges. I'm president of Koning Corporation Americas. We build the first FDA-cleared dedicated CurveBeam breast CT scanner. So thank you for being here today.
Okay. I'm Philip Patton. I'm a consulting medical physicist. I'm actually RadSite's chief physics officer. Been with the organization for 15 years, been a consulting physicist for 26 years, I believe, and I'm happy to be here.
Thanks, Vino. I'm Jenna Roller. I am the Director of Clinical Applications at CurveBeam AI. Have had the pleasure of working with RadSite as we specialize in orthopedic cone beam CT scanners. The niche that we have started developing is specifically a weight-bearing scanning capability that has been a unique feature in helping improve diagnostics in orthopedics. So thanks for having me.
Thank you, panel. So let's start having our session here. Oops. Okay. As a way of introduction, obviously, we are going to focus mainly on cone beam CT scanners and the radiation exposure from those scanners. And we give our most importance, to comparing conventional CT versus the, the novel, cone beam CT, scanners that we have, in the market. So before we get into that, I mean, why do we talk about radiation dose or radiation exposure, right? We all worry about all the, physiological impacts, that we get out of the radiation. For example, no matter what you do, we are still going to get some amount of, radiation from the background sources, But then the real concern these days, or at least in the last couple of decades, is that like when we talk about, radiation, from every source, the background source or the background radiation, it still stays the same. Whereas the man-made, talking about industrial, talking about medical, all the radiation or the exposure comes from that, it keeps growing. So it is in our responsibility to make sure, all the doses that we give to our patients that won't end up being too much radiation dose for the human population, that is already getting a decent amount of radiation from the background. So that's kind of the whole essence of like why we are talking about radiation exposure here. Let's see over the next, 45 minutes, hearing from our, elite panel members, how we could, mitigate the risks of, radiation risks, for the patients. And then, of course, how to, use all the CBCT, scans really, really effectively. So to start with that, of course, like we wanted to talk about all differences in, dose, from different, scanners. I just have it as conventional CT here. Of course, CBCT should be, more as conventional these days, So I sometimes name that as like fan beam CT versus cone beam CT. Sometimes I would just call it as also a spiral CT versus cone beam CT. And sometimes, people call more generally as, conventional versus CBCT. And that's what we will go with our discussion here. So then more we talk about the differences between those, then that will kind of bring us to a point where we can talk about are the doses, that we're talking here are very appropriate for all the clinical indications, that we are dealing with. And then we not only talk about the patient, doses, we have to be talking about all the operators, like the occupational exposure and stuff from there. And at that point, we can discuss more about like what all the safeguards, everybody needs to be doing, in minimizing the exposures. What in this world of technological advancements, what options we have, to bring that one. And then towards the end, what all the things we need to be doing really in the scanning world to optimize the radiation exposure that is coming from, CBCT. And then, of course, towards the end, we will have some, time for questions and answers. So with that, let's go into the, the first part of the, discussion, dose variations from, current standards. So we all know that, the dose profile and the dose metric is, very much different going from, conventional CT to, the cone beam CT. But then let's see, like if there is anything that we need to be, taking care of or probably take special attention to. We can hear from, Dr. Patton on, what dose profile differences we are having between, conventional CT versus, CBCT. If there is any dose metric variances, I know that we talk about, CTDI for conventional CTs. Would that still be a good metric, for CBCT scanners, or do we have to talk about, dose area product or Kerma area product, stuff like that? So, Dr. Patton, do we have more insights on that one?
We're still working through how we want to quantify the dose from CBCT as the equipment's changing. So obviously, if you file, you can actually do the same comparison using CTDI, but some of the equipment's set up where you can't actually get the same type of profile. So we have started looking at dose area product as a way to quantifying the beam along that line. But a lot of physicists still report the CTDI as our measuring tool. And as you know, if you do look at the CTDI, or you're looking at a factor of approximately 5 decrease looking at a CBCT. So as the technology advances, I think we actually can produce very good images at a very low dose. Obviously, and the price of equipment should be considerably cheaper than a conventional CT as well. It states here our doses are lower by 2 to 10 times, and those are unique. Those are particular protocols that we look at, but I think on average it's a 5-time. You can consider a 5-time decrease in dose. But we are still working out how we want to do the comparison if we want to actually fall to the CTDI as we've done for conventional. Obviously, as the dose comes down, we got to make sure the image quality stays up. And that's some of the challenges. Obviously, as you know, it's a trade-off between dose and image quality. And the CBCT units that we've been developing, or that have been developed, and seem to be able to balance those two pretty well.
Thank you. So yeah, as Dr. Patton said, the biggest difference, in terms of the dose, comes from the fact that the configuration of the X-ray in it, of course, everything else, could be totally different in a cone beam CT, but the source still is, X-ray. But then the biggest difference is kind of in the terms of configuration is, in spiral CT, obviously it's kind of straight beam, whereas, cone beam CT, as the name says, it's cone-shaped, beam. That's the major difference that causes all the other differences, that follows. In dose metric, as Dr. Patton said, we haven't come to a conclusion yet as to like what is going to be the best metric, because we are stuck in between CTDI from the conventional CT versus DAP from rad and fluoro, mainly. And over the time, I think there will be some clarity in it. But for now, between CTDI and DAP, we could pretty much define all the doses that is delivered by a cone beam CT unit. Now I know that even though both of them are categorized as CT, almost everything is different actually. Starting from system design, the image quality to some extent, and then, technological efficiency. Talking about technological efficiency, let's get our, experts, as to like what technological, advancements, we have. Not going into so much of, details, but at least I wanted to kind of, let, the experts start with, David. Can you just help us understand? I know that, or we all know that, CurveBeam CD units, they are very efficient in having the scanners go, faster. That's pretty much I know, from a physicist, standpoint. But yeah, we would love to know more from you on the efficiency of the CurveBeam CD scanners used for breast scanning.
Sure. So in the case of dedicated cone beam breast CT, we have to be mindful of the fact that we are looking at a comparison not to whole body CT scanners as much as we are looking at a comparison to mammographic dose. So that gives us that parameter where we are required to stay within that same dose level that is currently accepted in mammographic dose. The difference in the two modalities are very simple. We are using conventional cone beam scanning, but we're using that with a mammographic X-ray tube and a high resolution mammographic detector. We are not compressing the breast, but we are delivering a 7-second rotation around the breast that is pendulously inserted into the aperture of the cone beam table. So in so doing, we are able to achieve an isotropic data set that we can then produce a 3-dimensional image that can be looked at in any direction at resolution in the same range as mammography. So we worked very hard at making sure that we could meet the federal requirements that are in place for mammography exposures to our cone beam breast CT device. And we have achieved that, and we are in the same range. And this is the reason we received our FDA PMA compliance and clearance rather.
Yeah, sounds really good, David. So Jenna, do we have any such special things with the weight bearing or the extremity scans mostly? I know that you do a lot of head scannings also, but I think majority of them are extremity scans. So if you can kind of shed some light on that area, that'll be great.
Yeah, absolutely. I would say there's a couple of things that both Dr. Patton touched on and David touched on that resonate in our technology as well. And one is, I think, a lot of these technologies are very targeted at becoming experts in the diagnostic of a specific area. So for us, we're very focused on orthopedics. David is obviously very focused in breast diagnostics. But his comment about his comparison to mammography, we often get the comparison to X-ray, and even talking about the comparison to a series of X-rays, or what happens if the X-ray is inconclusive and now we have to repeat the X-rays again in a couple weeks, and now there's multiple different instances of the patient getting X-ray. And that's where we talk about a lot of our workflow changes and trying to get a definitive diagnosis for the patient sometimes earlier in that diagnostic pathway. The other thing that Dr. Patton mentioned is really that blend between dose and image quality and your diagnostic objective. In most of our scans, we really tailor our dose for bony anatomy. Compared to other applications in CT where they're using it for soft tissue diagnostics. In orthopedics, if you're looking for a soft tissue diagnostic, you're typically ordering an MRI instead. And so we've really honed in our dose parameters to balance image quality for bony resolution and focusing on that diagnostic profile.
Sounds really good. Sounds really exciting. Okay, so yeah, as Dr. Patton alluded to, the doses by having all these technological advancements, what we have in available in the market now, the doses could be anywhere between 2 to 10 times. Again, to pinpoint, probably it'll be like 5 or 6 times even lower. Again, it depends on what, anatomical area, they are scanning and stuff like that. So it's really a good win, to have all those specialized, CT scanners. Along those lines, when we talk about dose, obviously we need to touch a little bit about all the physiological, risks. Is there any difference in the way we perceive the, physiological risks compared to conventional CT, to cone beam CT? To my understanding, since all the physiological effects, it started, it start to happen after a certain level, just not kind of in the diagnostic range. But then I just wanted to get the expert's opinion. Dr. Patton, did they say that right in assuming that, the physiological effects, if any, it'll be pretty much similar to what we assumed, in a CT also, or, something there?
Yeah, so the effects that we're concerned with, they have the same source. They're an X-ray generated source. And so we are looking at the same type of impact. So the radiation coming in from typical photon causing the changes. But you're right, it's well above the diagnostic range. We've been using conventional CT for quite a long time, multiple conventional CT scans, and the CBCT with a lower dose will even have less of any effects. But we're not really concerned with the majority of the CT scans until we get to a large number, because as you stated, the actual concerns are higher than the diagnostic range of exposure.
Okay. Sounds good. That's what I thought, but I just wanted to, make sure I get your opinion on that one. So we're talking about like what, the CBCT scanners are kind of doses really low, less than by around like 10%, 90% or 80% or something like that. So would that mean that the image quality is going to take a hit? Let's look at that, when we discuss the next ones. So obviously, for those of us that are wondering, what the real numbers look like, in terms of doses, I just we just have this, table here. It kind of gives you kind of an idea where we stand comparing doses between a conventional CT scanner versus cone beam CT in kind of respective, imaging. Here the biggest takeaways for me was the head. Of course, it was going from 50 to literally to, 3 or 4 milligray. And that's the same thing with, breast biopsy. Look at that. In the conventional ones, it gives as high as like 60 milligray. And with the, the breast, cone beam breast CT, CBCT, it could be as lower as, 30%, like 50%, less. Anyways, so having all these, low doses, Dr. Patton, should we still, go with our ALARA principles, or do we have to modify anything in the ALARA principles working with a relatively lower dose environment in cone beam CTs?
So this is a concern in my mind for CBCT, because the doses are considerably lower, and people actually lose the radiation safety concern component. They actually start saying, "Oh, I don't have to worry about it," or maybe they're not knowledgeable about it. And since dental was one of the first ones to bring in CBCT, I think a lot of people start relating them to maybe a dental unit or a typical X-ray unit. But no, we actually do still have to adhere to the LAR principles. Our goal as clinicians or physicists is to make sure that we keep the dose to the patient as low as possible, even if the procedure is a low dose procedure. I think that's one of the driving forces of CBCT that brought it to the market, was the fact that you could get good quality images at less dose. But we still have to be, aware of that we're using the appropriate dose for the clinical study. We're not repeating exams because we didn't do what we're supposed to do. The exams need to have appropriate image quality, so we're not repeating them. And we do have to have policies in place so that we can follow, just like a conventional CT, where we're adhering to the LAR principle. And if you're not sure about the LAR principle, as low as reasonably achievable, and that's always our goal for every X-ray source that we use.
Thanks, Dr. Payton. Yes, that is always the essence of working with radiation sources. You have to be keeping it as low as reasonably achievable. So considering that, I'm pretty sure the technological advancements that we have in the available in the market, I'm pretty sure all the scanners will kind of take that into consideration in some amount at least. So I just wanted to get the the expert's opinion from David and Jenna as to like is the scanner that has been built these days, do they take into account all the appropriate dose for clinical effectiveness, and are they prioritizing image quality, all of them? And I know that Jenna, you touched a little bit on the how scanners are designed for all the specific clinical needs, and if you could kind of elaborate a little bit more as to how they are doing it in the field to kind of meet these goals. I'll probably start with Jenna. Can you please help us a little bit on that?
Yeah, absolutely. I think this is a really good point. And I give RadSite a lot of kudos for the fact of a lot of it comes down to education. And I think that's kind of Dr. Patton's point. It's our responsibility to make sure that we're educating customers and consumers about just putting good policies into place. Some of the ways that we have done that as a manufacturer is we design our scanners with different protocols designed for different patient sizes. So to Dr. Patton's point, if you have a larger patient that may need more dose, we also have low dose protocols that are designed for smaller or pediatric sized patients, so that in principle, we have a tailored system that the technologists or the operators of the equipment can make the right decision about how much dose each patient needs on an individual level, to still make sure that they're getting good diagnostic quality, but that they can tailor that to each specific patient and their size.
Okay, so that's good to know. Everybody is talking about like cutting down on doses for the betterment of the human population or the environment and stuff like that. It's good to know that you do have specific protocols for kind of the bigger size patients also, because obviously we are scanning patients not for the sake of irradiating them, but to get some good images. So it's good that you have it. For that, in that same note, David, in the CBCT world, do we have, difference in, protocols, for example, dense breast versus, small or large breast and stuff like that? Again, my, understanding on that is coming back to like ConeBeam CTs in breast imaging is very limited. So please forgive me if I said, anything differently there. So please.
Oh, that's quite all right. And thank you, because yes, it is a new technology, and it's one that we've worked very hard to make sure that we are maximizing the resolution of the image that is being delivered to the radiologist, but we're doing so in a very conservative dose environment. And we also have to be aware of the fact that we are carefully watched as carefully watched as the mammography industry in relation to dose for patients. So in our particular world, because we are a ConeBeam breast CT, the way that we manage that is we perform an 8 millisecond scout, very similar to conventional whole body CT. That helps us identify, in our case, the appropriate MA selection, because KVP and time is fixed. And so what we have is the opportunity to understand all of the parameters of that body habitus, whether it's adipose, glandular, tissue combinations, or even size and areas of penetration. So through that scout image, we are able to optimize the exposure rate so that we maintain image resolution that would be compatible with any form of image resolution that radiologists expect from current mammography equipment, including 100 to 150 micron type resolution. So we're very proud of the work that we've done in watching both dose as well as image quality. And I think it's showing very, very well in the marketplace right now.
Okay, that's a perfect way to do it, obviously, have dose on one hand and then image quality on the other. I'm just curious, I know that in CT, we are talking about the KVP from, 80 to like 140 kV. And in the mammograms, we are talking about what, 25 to, 35. So what would be the typical KVP in a cone beam, breast imaging?
So we actually have a variable KVP system that allows us for different features and functions to adjust our KVP from 29 KVP as high as 60. The average KVP is emulating more of the average KVP for digital breast tomosynthesis, which is set at 49 KVP. So that is where we start our exposure rating when we're doing conventional breast imaging.
Okay, thank you, David. So yeah, obviously, we kind of understand that all the, the scanners or scanner manufacturers are putting their efforts, in promoting patient safety by using all the, technological advancements. How about on the other side, you are talking about the operators? Like, what are the things, we have to consider, in talking about occupational exposure to our, radiation workers? So is there any exposure limits, to radiation workers, Dr. Patton? And if there is any, limit different, for CBCT versus other scanners, or is it kind of universally the same, the exposure limits? And on that same token, we're talking about like low dose, exams these days. So would that mean that, the operators, I'm talking about the technologists and technicians, do they not need any dosimetry badges anymore? So I just wanted to kind of, get your thoughts on that, Dr. Patton.
So the first part of that question about the exposure limits, the exposure limits are set up by national and international bodies to make sure that radiation workers are considered safe workers. Being a radiation worker, you're as safe of a worker as you are in other fields. And so the exposure limit's the same, whether you're working at CBCT, you're working at CT, or you're working in fluoro and such. And that's regulated by either the individual states who have been designated authority, or it's regulated by national organizations. And those are based on, studies of different type of exposures throughout our history. And we've been able to see what is considered safe. So for CBCT, yes, if you're a radiation worker, you will still be held to the same radiation limits for the different body parts and the whole body effective dose, deep dose. So the second question you asked, were dosimetry badges still necessary? And that's not a straight yes or no question, because the amount of radiation a worker may receive depends on a lot of things, the proximity to the unit. So that kind of decides about what the size of the room is, what type of shielding is available. Are they outside of the room, or using some type of leaded glass to see what's going on, or are they not shielded properly? So the states, which have authority through the NRC, they designate that if a person is likely to receive 10% of their annual limits, they have to be monitored with a dosimeter. So the way that you do that is people are monitored until you're proven that you're not going to receive 10% of your annual limits. So, so are they still necessary? Initially, I think they're still necessary, and you can later on prove that this worker has never received anywhere close to the 10%, and therefore they do not need to be monitored. The regulations, again, are not straightforward that, hey, you work in CBCT, you have to have a dosimeter. Again, it's based on the 10% of the annual limit, and you have to prove that you do not need a dosimeter. Otherwise, you do have to have a dosimeter signed. And so my clients who are in any field that deals with radiation, whether it's CBCT or traditional radiation, like typically surgery, where they're sometimes in, sometimes out, we err on the side that we monitor them, because too much data is really not a bad thing, but lack of data, it's hard to come back and actually quantify what happened.
So on that same token, if they don't receive that 10% radiation at all, exposure at all, would you recommend them to kind of drop using badges altogether, or would you recommend them to put a control badge in the area and kind of that way at least some amount of radiation is being monitored?
Yeah, so that would, if we're going away from individual monitoring of the workers, typically you assign an area dosimeter. And that way, that's a worst case scenario where that's a full-time worker operating the machine constantly. You get a dose estimate of what that is. So from that, you can actually determine, a conservative determination of what the workers would receive. But the real beauty of that is you can see if that number starts climbing. If there's a change in the environment where you said, hey, they don't get 10%, but there's been a change in the environment because this dosimeter is now receiving, 1.5 times what it used to. Do we need to reinvestigate if the workers need to have dosimeters? So yeah, an area badge, especially for the cost and the ease of use, it's a no-brainer, basically.
Thank you, Dr. Patton. So yeah, I mean, talking about all the low radiation that you're receiving and talking about all the badge requirements, for the radiation workers, I'll probably, turn to David and Jenna to get this, part. Does that also mean that, the operators still should be wearing the lead apron, for example, when they do these scans, or is there any, anything that in the new scanners, that are coming out in the market that has something that will take care of all the, the scattered radiation before that reaching the operator, that they don't have to wear any lead apron. So what do you guys see in the field, the sites doing in terms of, personal protective equipment? Let me start with David, on, breast imaging. What have you been seeing at your customer sites, and what do you have in the equipment, that kind of helps, the radiation workers, in getting less?
Sure. Yes, Vino, and I think that the easiest explanation that I can provide is that when we deliver a system, it's a two-part system. We have the table that the patient lies on. That table is completely shielded, and the only part of the body that is exposed is the breast. So there's no other parts of the body that are being exposed to the primary beam. On the operator side, there is an operator console, and that operator console is either going to be positioned behind what our factory provides as a glass lead barrier that is very near to the patient table side, or it can even be configured to see if it's a room that already had a winged wall that was in place with protective lead glass, we can set it up that way as well. But at no time does the patient stay in the room with the patient during the exposure. So if we try to replicate what we've learned over the years with mammography machines, it's set up very similar. The patient is on a table and the operator goes behind the lead glass protective barrier to make the exposure, although the exposure in this case is very, very low, but I think safety is paramount, and this is just a great way to configure our systems as we prep for delivery and installation.
Okay. Thanks, David. So in the weight-bearing, ConeBeam CT world, Jenna, so what do we see there?
Yeah, I would say it's very similar to a lot of what David described, and Dr. Patton touched on this a little bit too. We have had to make our systems flexible enough that they can be installed in a number of different areas, and there are different state regulations that we still need to comply with. But as David mentioned, we utilize a lot of lead lining in our covers and the equipment itself so that it protects the patient that is closest to the beam source. And then we also we have a operator workstation very similar to what David described. And we work so that that is either nearby and protected, or we have a number of rooms to be compliant with their state regs where there is a wing wall or some type of other installed barrier that protects the operator where they're using the exposure button controls.
Okay. So in that case, I understand, that, it's pretty much similar to conventional CT rather than anything like fluoroscopy or cath lab, situation. Most of the cases, like depending on the room size that Dr. Patton said, depending on the room size and the workload and whatnot, most of the times, it will be very similar to the conventional, CT then. So that's good. I do not know whether it's that much of a occurrence these days, in holding the patients, for CBCT scans. But if that is the case, from the discussions that we just had, I understand that it will be exactly the same as the conventional CT. Also, if there is anybody holding, a patient, then they would be encouraged, to have, on them. Did I say that right? Okay.
On my side, yes. Yes, there would be no need to be near or hold the patient.
That's right. In ConeBeam, breast, CT, probably, yeah, there won't be any need for it, but yeah. Okay, got the point. So yeah, I mean, talking about all the occupational exposures, now let's move on to see like what all the things, we could be doing, from both the operator end and from the, the manufacturer end to see, the safeguards in minimizing, the exposures. Of course, like when we talk about minimizing radiation or minimizing exposure, we always talk about time, distance, and shield. The time is probably the first one, and that's kind of on our way, using CBCT scanners because the scans are much quicker, than other ones. So the distance, it depends. We will talk a little bit about that. And then the shield. So those are the two things, that's kind of very much variable, depending on what facility or what machine it is we are talking about. So let's talk a little bit, more on that. My favorite topic is, patient shielding. Dr. Patton, if you can just help us a little bit understand there. These days, I know that a lot of sites, they are going away from using, patient contact, shielding, because of so many, different reasons. But from a physicist, standpoint, if you can tell us a little bit about why, shielding is not the same standard as it used to be like 3 or 4 decades ago, and if they're not, shielding patients these days, how are the departments, taking it? I mean, how is that culture change affecting it? In other words, I'm trying to find out how receptive, the facilities are, if we don't have to shield, patients anymore. This is not very much related to CBCT, but I think it is about other, modalities as well. So Dr. Patton?
Yeah, so as you mentioned, the patient shielding topic has been reinvestigated. The AAPM and the ACRs come out with guidance saying that we shouldn't be shielding patients. And then you want to look at, well, why is that so? Because we used to always shield them. And so there's a couple reasons that are dominant. One is the equipment's changed. I mean, the equipment that we use changed. So there's less leakage radiation. There's less off-axis radiation. So in general, we're able to localize the beam in a better fashion without having radiation outside the beam. And also the other issue is, if you improperly place the shield and it's maybe inside the primary beam, with the new equipment, most of the time it's going to drive the beam up. The KVP is going to go higher, the MA is going to go higher because it's automatically controlled, and now we have a large attenuating body in the beam. And so now we're going to give the patient more exposure. And so with the balance that mainly we're getting almost all of our exposure from the primary beam, and there's the possibility of accidentally getting the shield in the primary beam, causing that to increase. You're not saving any radiation to the patients, as a general population. So a lot of the facilities I dealt with, they've accepted it really well, although they were shocked when it was first introduced. Like, really? And why have they accepted it well? Well, it's less things to worry about. It's it speeds up the patient throughput. It reduces having to keep up with the shielding and monitoring the shielding. Some of the patients still have questions on it because either they're familiar with the shielding practice or they've seen on TV where somebody who knows very little about radiation will talk about shielding. But if the technologist doesn't, properly place a shield. Again, like I'm saying, a lot of times they're doing more harm than they were even doing good back in the old days when, there was a concern about off-axis radiation. So most of our facilities, if a patient is adamant about having a shield, they will supply them a shield after they explain to them why there's been a change in that. And if they're still adamant about it, they will still supply them a shield, but they make sure they keep it well outside the primary beam. So.
Thank you, Dr. Patton. As a physicist, I pretty much take the same stand as you did, and just for the same reason that you mentioned. Most of the cases, shielding is not that very, effective, in cutting down the primary beam. To say most of the times, it is tried to reduce the secondary, radiation, and it's not that much, effective. And second, it could cause problems by creating artifacts or probably, kind of coming in the way of the diagnosis if it is not, positioned properly. I'm thinking more of gonadal shieldings, that is kind of causing, more problem than more help there. So yeah.
And it can easily block some anatomy where they can get diagnostic information from.
Yep. Totally agree with that. So obviously, the practice would be like anything, just that's just the way we do it in CT. If the patient is adamant, in getting some, shielding, for example, if there is a pregnant patient, getting a chest or a, head CT for that example. Yeah, if that's the case, you can just provide them that. But then, either way, it's negligible, the benefits or the negative ones. So thanks for that, Dr. Patton. So talking about shielding, we talked about patient shielding, but how about the shielding in the room? So probably this is more of a question for David and Jenna. I'll probably start with David. Two questions, of course. The first is, do you think for all the breast CBCT scanners, if the room shielding is necessary or appropriate, and is the room size going to be any different than what they are used to in breast imaging, and do they have to worry about any occupancy around the scanned rooms? So I know that I asked too many questions there. David, if you can get us your ideas.
Sure.
Yeah.
Yes, absolutely. So as I mentioned earlier, we do build this machine with internal shielding. It is a fully shielded machine. Now, as it applies to the shielding of the room itself, we have often counseled our customers that we're taking in machines to communicate with their medical physicist of record so that they can determine if local authorities require shielding, regardless of the device that is going in. That's not within our bailiwick. Ours was about protecting the patient and of course, making sure the safety of the operator was taken into consideration. But the room, we leave that to the state and to the facility's medical physicist to determine if they need to add shielding. If it does not already exist, much of our product will go into existing rooms that probably have legacy shielding in it from previous pieces of equipment that were in the room. And as far as the size of the room is concerned, very similar to mammography rooms, our device can fit into a 10 by 10 or a 10 by 12, and in some cases 10 by 14 room, depending on what the facility has available and how much work they want to do on the system, including 3D guided biopsy, which would require you to have a little bit more space around the unit.
Thanks, David. So Jenna, is there anything different in the weight bearing, CBCT area, or is it similar to what David suggested?
No, a lot of the same concepts, right? It's the equation that you started with on this slide. For us, we're really trying to make more advanced diagnostic imaging easily accessible at the point of care for a number of our customers and their patients. And so we have the privilege in a lot of ways to fit into a number of rather small spaces. Our smallest scanner that's designed for upper extremity is only about 2 feet by 3 feet. So we've had some folks convert a storage closet that was not in use. But in those instances, your point about distance, it's much smaller. And so We have taken and learned a lot from our physics colleagues. Folks will ask us often, do we need shielding? And usually my first question is, well, what's on the other side of your wall? Because that often is it an elevator shaft or is it an administrator who's sitting there at their desk all day? So a lot of those things do need to be taken into consideration, but overall, we have found if it's a former type of X-ray suite, similar to kind of what David was saying, if this has been previously used in a similar capacity, it typically doesn't need anything extra. But if it is a room that we're converting, you might need to think about that just to be compliant as well with your state regs.
Okay. Thanks, Jenna. So the biggest thing I understood from here is like, yes, I mean, we are so happy to have a smaller room, for CurveBeam CT, but now we have to take distance into consideration. Thank you for that. Talking about the other things about, safety, the last one, I have this question is to, find out about patient holding. I know that, David, in your case, it's not as much of a question. Jenna, do you see it as a normal practice that where patients need to be held, or is it kind of going away these days? Do we have anything, in the CurveBeam CT area that helps patients so that they don't need any, holding anymore?
Yeah, I think you bring up a really good point. We have a number of accessories that we provide with our scanners to try to mitigate the need for that, to try to really limit the exposure to the technologist. One of our most common areas is in the pediatric space, and it's more that there is an adult chaperone. So it may be that there is a child that's apprehensive or someone who's in pain. And then those facilities typically defer to their existing policies and procedures around having other people around. But we use a lot of strapping, a lot of accessories. We have some stabilizing devices that we have designed to really help keep that at a minimum.
Thank you. Yeah, that should definitely help, in taking steps towards minimizing, exposure. So, yeah, talking about all that, that will kind of put us in a spot where we can talk about a little bit about the optimization. It kind of goes a little further than kind of the steps to safeguard safety. It's all about balancing between the image quality and the safety also. So probably the most important component to any department's patient safety goals. So as usual, I'm a physicist. Probably I'm more biased. So I'm just going to get Dr. Patton's ideas first. I'm talking about since the radiation is kind of much lower now, does that mean that we could be a little lenient about all our optimization measures, or it's not the case, Dr. Patton?
Well, it's not the case. And again, back to the LAR principle, we want to keep the dose as low as reasonably achievable. The way we set up our standards and our safeguard is we use the linear no threshold model. So we believe in the linear no threshold effect, or at least we implement it, where that every radiation has the potential of causing an effect. Whether that's 100% accurate or not, it is a conservative way for us to look at the radiation exposures to our patients or to the workers, and set up safety guidelines that allow us to make sure that we're very conservative on how we look at the safety of this population. So we do have to make sure that we're still optimizing our protocols. Again, we're not just repeating exams because we want to repeat them or we think we could do a slightly better job. We need to have the best quality images for the lowest dose at all times.
Thank you. Yeah. So talking about that, I'll just go to Jenna first. I know that you already, talked about how special, efforts, ConeBeam CT scanner, manufacturers have taken, in kind of optimizing the dose for large patient versus small patient versus, different or special case patients. I'm talking about, any metal in the body, right? So that's best way of controlling, the primary beam to mitigate radiation risk, obviously. And then I want to also understand a little bit about if there is any active, dose optimization techniques, that they can use. The only thing that comes to my mind is just AEC, but then, the other, things in the, scanner that the operator can use, in actively, optimizing the dose. And of course, on the same lines, I wanted to also know, is there any special, care taken for, scanning pediatric patients, things like that. So, Jenna, your thoughts on that?
Yeah, so I think one of the things that was brought up here, and it's the last bullet here at the bottom, is around dose reduction at the expense of clinical image quality. So we have often worked with a number of our customers and also with their radiologists to go back and find that balance, do some case studies, go through and look, because the other thing you want to balance is you don't want them to have to repeat scans, right? So it's one thing to pick the right dose, but then if you kind of overshoot your goals of dose reduction, and now we're not getting adequate image quality and scans are getting repeated, that's not something that we want either. So we found that in addition to optimizing the protocols on the equipment, creating different designations for different size patients, we have found that doing those case studies and kind of doing some image reviews with both, your radiologist and within your organization, that can be another thing that's really helpful to make sure that you're getting it right from the beginning. And it's one of the things that's been really helpful for a number of our patients who go through the accreditation process. They've learned a lot from that.
Okay.
And I would encourage folks to, kind of have those quality meetings and take the time to talk through those things, because it is a good opportunity for everybody to come together and talk about where, there's room for improvement, where we could be doing better, but also focus on the things that they're doing well in terms of following those ALARA guidelines.
Thank you, Jenna. That's a very valid point of getting the feedback, from the radiologist on image quality. That would be kind of a number one priority, actually, we should have, because we wanted to give the radiologists, the images they like. So that would probably constitute a very good, robust, optimization program, whether you have it, at your facility or probably in a network level, that will help. David, I know that pediatric scanning is not, going to be that appropriate, for, breast imaging, but how about all the other, efforts in controlling the primary beam? Do we have anything more to learn from whatever we talked in the previous, sections?
Yes, well, we mentioned the fact that as long as we are following the calculation that is provided from the scout image, then generally speaking, the appropriate technique is used and the dose is optimized for that particular patient breast composition. Other than that, it's carefully monitoring all of the components from the actual X-ray tube itself, the anode material, the angle, the focal spot size, the collimation, and then making sure that we're fitting that beam only inside of the active detector area. So I think through our service and through our PMs, we are checking these consistently to make sure that we are making the safest exposure we possibly can, but still obtaining that high resolution image demanded by the breast imagers.
Yeah. Okay. So yeah, I mean, talking about optimization, right? I mean, that's the thing. Everybody talks about reducing, the dose without compromising or without taking care of all the the image quality shortcomings, so which is not right. I mean, that's the reason why whenever I go to different hospitals, I don't say dose reduction, I always say dose optimization. That kind of takes the image quality into the discussion. So that should be at the bottom of all of these. So yeah, we kind of agree that yes, ConeBeam CT scanners, they are due to the technological advancements and drastic difference in radiation exposures. Obviously, we tend to take a step back when it comes to safety. Rightly, as Dr. Patton said initially, that is a big concern. Saying, are we taking it lightly? CBCT scanners. So the kind of the crux of whatever the discussions we had today is, do not take the radiation lightly, and do not compromise anything on the image quality. That's kind of the two essence of all the discussions that we had today, I think. So is there anything else that you have, Dr. Patton, Dr. David, and Jenna, if you have as closing comments?
Oh, nothing to really add to this, other than I'm very excited about the CBCT technology. I think that as we've discussed, it's a smaller piece of equipment usually, so it's easier to get into facilities. The radiation exposure is less. The image quality, once all the physics of cone beam technology was worked out, the image quality is where it needs to be. And I think it brings this type of scanning to a greater population.
Thank you.
Yeah. And I have to agree with Dr. Patton. This is an exciting time for X-ray emitting devices to see cone beam come into so many of the specific areas to image the body, save some dose, improve our image quality, have better safety. And in the case of breast CT, I think one other factor that should not be overlooked is the fact that this is the first time that we can offer low dose imaging for breast cancer detection without having to use the discomfort or pain from compression that is currently an absolute requirement in mammography machines. So I think that's going to help us with patient compliance and a number of other things that are concerns within the medical community. So we're very excited about that.
Thank you, David.
Yeah, I think, you did a great job. This was a really good discussion, and I think it helps a lot of different folks from different positions understand, this type of technology. With David, I think it's on our end as well. It's been a lot of fun. It's been really exciting on my end to just also see the difference in orthopedics when we now have an imaging modality that offers the diagnostic and alignment information that is given to an orthopedic surgeon when the patient is standing, right? It's almost maybe the opposite of David's. The compression that's required in mammography, orthopedic surgeons have had to compromise on, well, it would be great to get 3D information, but I lose all of that functional weight-bearing alignment as soon as I lay that patient down on a table. And now they're getting the 3D information and the weight-bearing alignment information in the same study, that they can now be much more precise in their surgical planning. And it's really leading into a number of personalized orthopedic planning applications that are really coming along right now. And it is a really exciting time in the field.
Thank you, Jenna. Thanks, panel, for having very good and exciting discussions. So with that, let's see if we have any questions from the audience.
I think we've got time for one quick question before we close out the webinar, and I'm going to read it. So most CBCT physics testing is done by using the manufactured phantoms. Are there any phantoms under development or in commercial use that can measure radiation dose and other measurements in a standardized fashion? Got a couple minutes if anyone has any feedback on that.
Dr. Patton,
There are actually,
yeah.
Go ahead, Vino. I'll let you have it.
I was asking whether you can go ahead and take it. Yeah, please.
There are different quality control phantoms that are third party that are being investigated to be used for all the vendors. And I'm not sure about mammography, CBCT, but the traditional ones that we're referring to. And we still are looking at using a smaller CTDI phantom for measuring dose. Again, that's, as I mentioned before, it's a little tricky on the geometry and the setup. So we're constantly evaluating that. But there are third-party vendors that you can measure the actual quality of the images. My group, we use a third-party vendor instead of using the manufacturer's phantoms.
Yeah. So yeah, I was going to say exactly the same thing that you did. Yes, I mean, manufacturers, they know their, system really well. So they kind of come up with a phantom, that would best fit to test the image quality on that one. However, for the, the dose, even though we haven't come to a total consensus on like which one to follow, at least, like we have kind of a more generic phantom that we could use, in pretty much any, cone-beam CT unit in measuring the CT dose. That's what kind of the standard right now. But I know that there are a lot of research groups, they are trying to come up with a unified, CBCT phantom, but I haven't seen that in the, the market or in the field yet. So, good question, but probably we'll see something on that real soon. But for now, we will have to take a hybrid approach as using a generalized phantom for dose, and then, specific phantom for, the QC image quality.
Mm-hmm.
Well, one of
Wonderful.
the concerns with measuring that on the physics side is the manufacturers are very different. Their geometry is different. Their specifications are very different. And even some of the parameters we're measuring from one vendor to the other, their standards of what's acceptable is quite different. So we have to actually collect a large amount of data before we can actually say, this is what would be passing for all vendors for a particular element that we're measuring. For example, if we're measuring the CT number accuracy of a material, some vendors have it, considerably different than another vendor. So as we collect more and more data on this, we can actually narrow that window down and possibly assign a region that would apply to all vendors.
Wonderful. All right. Thank you so much for those very informative responses. RadSite would like to thank our moderator, Dr. Vino Durairaj, and our presenters, Dr. Philip Patton, Jenna Roller, and David Georges. If you have additional questions, contact us at info@radsitequality.com. Just a reminder that today's webinar has been recorded and will be available through our website. If you enjoyed this presentation, be sure to check out the webinar page on our website and RadSite's YouTube channel for past webinar recordings. We hope you will join us for upcoming webinars. This concludes our webinar today, and thank you so much.